I'm very happy to introduce today's speaker. I was about to say a distinguished alum of the Population Study Center, but I could just say an alum of the Population Study Center. We just keep turning out distinguished alumni, so this is all good. Matt Ruther from the University of Louisville. You're in the Department of Public Affairs, Urban Affairs.
Urban Affairs.
Policy, right?
Urban Affairs.
And you're the head of the Kentucky State Data Center.
Yes.
Yeah, okay, so this is all good. He's going to tell you about the work he's doing now. He has a considerable curriculum vitae, and one of the things I've noticed, I know you're still working with Janice, right? I mean, you guys are
Always.
But so Janice isn't here to defend herself, but you get a very strong technical training in demography here at Penn, and I'm really impressed that so many of Matt's contributions are in the area of technical demography that we don't do at all. So he obviously learned it elsewhere on his own. A small area estimation, which when you actually leave here is the only thing people are really interested in demography outside the pop center. Inside the pop center, we're desperate to know the population of Tanzania or something like that. Outside of the pop center, they're very interested in knowing what the county population or smaller area population is going to be. So if you haven't already talked to Matt, he can give you a little view of what's important to learn. But I digress. Matt, it's really nice that you're back. Have at it. And
all right.
All the usual rules, you're on your own.
All right. Well, thank you for having me. I'm honored to be here. Like Herb said, I am the director of the State Data Center and sort of the de facto state demographer for Kentucky. And so I talk to a lot of people, and a lot of the press, not the big press, but not CNN is not calling, but the Paducah Sun calls very often. And they never want to know anything about what I'm working on. They only want to know the applied section of what I'm doing. And so it's really important to have these two influences. So everything that I'm going to present today is co-authored with Ning Shea, also a graduate of the Penn Population Study Center, and she's at Michigan State now. And back in 2010, she and I went to a session, or sort of an informal meeting session at PAA on sexual minority health. And we met some of these researchers that were doing this type of work, and there wasn't a whole lot going on at the time because data limitations make it hard to study this population. And so we were really excited. We were sort of gung-ho about doing this kind of research. And so 5 short years later, we ended up with starting actually working on it. And so we've developed this sort of agenda that just follows along this line of research. And so today I'm going to sort of push this all together and present sort of an aggregation of what we've been working on, what we worked in the recent past, what we're doing now, and what we hope to do in the future. So the prior research in sexual minority health, I'm going to go through this fairly quickly. Prior to about 2000, most of and when I say sexual minority, I'm talking about anyone who doesn't identify as heterosexual. So really I'm talking about gay men, lesbians, and bisexuals. Other groups, anyone that identifies as another group is, for data reasons, is actually not included in this in anything that we do. But sexual minority is sort of the expansive definition for all of these individuals. So prior to about 2000, most of the research on sexual minority health looked at disease-specific outcomes, and the majority of this research, about 60% of all articles published that included a sexual minority component were about HIV and AIDS, because that was the big thing, in the 80s and 90s. The rest of what was published was almost all on mental health, and there was very little actual research on health behaviors and health outcomes outside of HIV/AIDS. Since that time, there's been a lot more research, and generally, we've come up with about 3 main findings. One is that the LGBT population and I'm going to use the T, although there's also no transgender people in our sample for other data reasons. The LGBT population is generally less healthy, so they have lower self-rated health, and some other health outcomes have disparities with the straight population. Part of this is related to a higher incidence or a higher prevalence of risky health behaviors. So smoking, drinking, sexual behavior, higher risks. These higher risk behaviors are more prevalent in the LGBT community. And also this community has less access to health care. And here I'm just talking about having health insurance. And so we have these disparities, and we are interested in sort of doing some updated work on what these disparities look like currently. So, although this research there's a lot happening right now, there are some limitations to this research that warrant this restudy of it. One is the generalizability. So, not so much now, but in the 1980s and 1990s, a lot of the samples that looked at LGBTs were convenient samples, and so researchers would go to bars and talk to people there, and obviously there's a big problem with generalizability and selection here. There's also an issue with geographic specificity. A lot of the samples were done in California, and so you may have a population that's representative of California, but not necessarily representative of the entire United States. They also had really small sample sizes, and so while you could look at the LGBT population, you couldn't, say, stratify it by race, or maybe take bisexuals out of the lesbian and gay groups. So there was no study of the heterogeneity within these groups. And lastly, there's just been a big change in the last 20 years in the social, political, and legal landscape for the sexual minority community. Social acceptance has increased a lot, and there's been a number of court cases that have increased the visibility and increased the access to care of this community. And so these are some of the reasons why we wanted to do this research. So our research advances the field in that we have these large population-based samples. They're representative of the US population. And the large samples allow us to stratify both by race, ethnicity, and sexual identity. So we can separate bisexuals from the LG population. We also look at an expanded definition of access to care. So we all know that having health insurance is great. This is what we typically use as a proxy for access to care, but there are lots of other things that come into play on whether you actually get care. So can you afford it outside of the health insurance? Are there other barriers to getting to a doctor or getting to a hospital? Are you satisfied with the care received? So we look at this expanded definition, different outcomes for access to care. And then we do an exploration of same-sex partnership benefits, which has not been yet done, and we are in the future adding neighborhood effects to this research. And I'll talk about that in just a minute. So an example of these sample size issues is here. There's 4 big surveys that researchers use. Prior to 2013, this is what you had. You had the NHANES, which is the National Health and Nutrition Examination Survey, and the National Survey for Family Growth. And both of them had fairly small sample sizes, particularly NHANES. So we had an annual sample size of about 37 for men. And this is maybe big enough to do research on that population, but you can't do a whole lot with it. The National Survey for Family Growth was a little bit bigger. The issue with this survey is that it's limited to 15 to 44-year-olds. So we were getting a select group of the sexual minority population. And this explains why some of the numbers are higher for those groups because of the younger population. In 2013, the National Health Interview Survey started asking sexual orientation questions. And these were much larger samples. Obviously not as big as we'd like. We would, everybody wants bigger and bigger samples, but significantly bigger than the NHANES was. And then in 2014, the BRFIS started asking sexual minority questions, and these are the biggest samples of all. And so we have all this new data coming out, and every year, obviously, this what is available gets bigger, that we can use for these studies. And so there's been a big explosion in what we have available. So I'm going to talk about papers 1, 2, and 3, which were the first 3 papers that I showed you in that first slide. And so there's going to be a different data sections, but all the data is essentially the same. There's just some small differences. So this first study looks at health behaviors and simple health outcomes for the sexual minority population relative to the straight population. We use data from the National Health Interview Survey from 2013 to 2015. The actual survey has about 104,000 respondents. Our sample size is 90,000. We exclude anyone who identifies with a sexual identity other than straight, lesbian, or gay, or bisexual. So if you answer something else, don't know, or if you refuse to answer, you're excluded from this sample. We also, because we're stratifying by race, we exclude we exclude all races that are not white, black, and Hispanic. The reason for doing this is that the number of, say, Asians, American Indians, particularly among the sexual minority groups, is way too small, and we don't want to cloud our findings with racial differences that we can't identify. The non-white group, we make these 12 groups based on sexual identity, which is the straight, gay, lesbian, bisexual, gender, male, female, and race. We have a white category and a non-white category that includes both the Hispanics and the black population. And then we control our regressions for the Hispanic population. I have a little asterisk on the sexual identity. So obviously sexual identity or sexual orientation or sexual behavior are a bunch of different questions. There's a lot of ways that people might answer these. We go with the standard, I say standard because it's the one used most often in the literature, of identifying identity based on people's response to the orientation question. So what do you consider yourself straight? Do you consider yourself gay, lesbian, or bisexual? There are additional questions on behavior, particularly in some of the NHANES and the National Survey for Family Growth. Ask questions on, how attracted are you to men 1 to 6, and how attracted are you to women 1 to 6, and have you had sexual experiences with? So these more behavioral questions. We do not deal with those in these particular studies. In general, the orientation question gives you smaller samples. So about 3 to 4% of the population will identify as lesbian, gay, or bisexual in nearly all the surveys. It's pretty standard. The behavioral questions give you about 6 to 7% of the population identifies as some behaviorally non-heterosexual. So we look at the health behaviors. We look at 3 health behaviors: smoking rates, moderate to heavy drinking, and obesity. We just look at differences by the 12 groups and then adjusted for socio-demographic factors. The LGBT population tends to be a little bit younger. It's generally a little bit poorer. The gay males are a little bit more educated than straight males. The lesbians are a little bit less educated than straight women. So these socioeconomic or sociodemographic differences are going to play into what these behaviors look like. We then do some logistic regressions on 2 health outcomes. We look at low self-rated health and functional limitation. So low self-rated health in the NHIS is a scale of 1 to 5, with 1 being excellent and 2 being very good. We consider those good health, and individuals that respond to health of good, fair, or poor we consider them poor health. And then functional limitation asks whether individuals can walk 3 city blocks, carry 10 pounds for some distance, these types of sort of basic movement or dexterity type activities. We run base regression models, and these are logistic regression with age, marital status, education, Hispanic, and the immigrant status controlled for. And then we run final models that add health behaviors. So we add health behaviors for these outcomes, and then access to care. And access to care would include having insurance, the ability to pay, saving medications, and those types of things. So there's going to be a lot of graphs, just FYI, because I like making graphs. And they're all going to look kind of the same. we're going to have 12 groups on the bottom: white males, non-white males, white females, non-white females, and then straights, lesbian or gay, and bisexual within each of these 12 groups. And they're all going to look about the same. Okay. So these are the marginal probabilities of a respondent currently smoking in each of these populations. And you can see, well, one thing that's quite obvious is these are confidence intervals, 95% confidence intervals. One of the things that's quite obvious is that the sexual minorities have wider confidence intervals because they're smaller populations. But in almost all cases, the sexual minority population exhibits higher smoking rates than similar straights. So among straight white men, among straight non-white women, and the female groups, the sexual minorities are more likely to smoke. When we control for sociodemographic factors, there's very little change. In fact, for some of these groups, lesbians, gay men, the sociodemographic controls actually make the smoking rate increase, which is somewhat surprising. We would expect it to go down. I would expect it to go down. And so we do still see these higher smoking rates among this population. The LGBT population also exhibits higher prevalence of drinking moderately or heavily. I don't remember the exact definition of moderately or heavily, but it was maybe 5 drinks a week or something more than that. Somebody here probably knows what the exact definition is. But in all cases, the sexual minorities exhibit higher rates of drinking. And again, these behavioral differences do not disappear when we control for sociodemographic factors. These disparities still exist. And finally, with obesity, we see a little bit more of an interesting picture. The sexual minority women are more likely to be obese than the straight women in each of the racial groups. But gay men and gay white and non-white men are less likely to be obese than straight men in those categories. And so here's where we see a gender difference, right? So controlling for sociodemographics, again, doesn't make a whole lot of difference here. So the reason that we're using confidence intervals instead of point estimates is that there's a lot of comparisons going on here. Okay, so we're going to, in the rest of the analyses, we're going to be comparing to straight white men because this is the group that has the most privilege. But there's a lot of other comparisons. We may want to compare women to other women. We may want to compare non-whites to other non-whites. So, trying to work through all of these comparisons works best with the confidence intervals rather than the point estimates. So we then look at the results of the logistic regression, the odds of having low self-rated health. And all the rest of the graphs that I'm going to show you, the y-axis is going to be the odds. Okay, so these are odds. Obviously, there's going to be a line at 1. This is straight white men, the reference group. And so we're looking at whether these individuals are more likely to have low self-rated health than straight white men. We see some gaps here among women, although less so among the sexual minority men. And when we control for access to care and health behaviors, these gaps mostly disappear. There is still some difference with bisexual white women and bisexual white men, but really the big difference here is not in sexual minority status, but in racial status. So we see straight non-white men and women show bigger disparities than the sexual minority groups. So so Ning does work on intersectionality, and so she talks a lot in papers about intersectionality. I'm less comfortable talking about intersectionality because I don't really know that much about it. And when we presented this paper at PAA last year, people did not like us saying this was intersectionality because this is really just stratification. The intersectionality part is the fact that you may have these different identities. So if you consider non-white a less privileged identity, if you consider sexual minority status a less privileged identity, and women a less privileged identity, then individuals here may have three non-privileged identities, and others have 1, 2, 0. But the way that the privilege and non-privilege works is not additive or multiplicative. It depends on other factors. Okay, so in many cases we're interested in the racial component because it shows up better, because it shows the disparities, and in other cases the sexual minority status. So among functional limitations, we see much of the same picture. Women, particularly sexual minority women, are more likely to have a functional limitation, and controlling for health behaviors and access to care do not make any change here. So we still see these disparities between men and women. So comparing our results from this paper to prior research, we find that the differences in risky health behaviors remain. So nothing there has changed dramatically since what you see in the literature. However, the difference, the fact that we find no self-rated health disparities between lesbians, gays, and straights is sort of novel. This is surprising, but the reason why it may be surprising is that we pulled bisexuals out, and they still exhibit these disparities. So it's possible that in the literature where these disparities show up, it's because the bisexuals and the gays and lesbians are all considered as one group. You'll see throughout everything that I show that the bisexuals are always disadvantaged in pretty much every outcome. We do see some disparities between lesbian and bisexual women, with straight men and women in the presence of functional limitation. So one of the things that we were really focused on in this paper is looking at how the different controls affected health behaviors or affected health outcomes. So we had health behaviors and access to care, and we were, which one has the bigger effect? This is much harder to actually come up with an answer to. They both had effects in different ways. But both of these factors together explain many of the self-rated health care gaps, but not the gaps in functional limitation. So the theory that we have come up with for why this is happening is that functional limitation develops over time. So it takes a longer time to get to that point where you're unable to lift things or carry things. And so these behaviors and access to care, which are more of the proximate determinants of health, may have less of an influence. So there may be something happening in the process that's not quite as obvious. In something that I didn't show you, we compared the difference in the effects of the health behaviors to the access to care, and it shows a really important change in health outcome odds when access to care is controlled. And I consider this sort of surprising. We often think that we know that health behaviors matter, right? Smoking, obesity, these are things that we always hear about. And we would assume that access to care matters, but my assumption was that it would matter less. And it turns out that it matters actually quite a bit. Given that access to care is so important, we look in paper 2 at some differences between the sexual minority population and the heterosexual population in access to health services. Like I said, we use an expanded definition of access to care. We look at whether they have health insurance, we look at whether they can afford health services, and we look at whether they're satisfied with the care that they get for those people that did seek health services. Historically, the LGBT population has been less likely to have insurance, and the reason for this disparity is that they were generally unable to obtain employer-dependent coverage. So if anyone doesn't know how the insurance market works in the United States, I don't either, but it's generally true that people get insurance through their employer. And if you are married, then your spouse comes onto your insurance. If you are same-sex and married, then in many cases your spouse is not eligible. And of course, if you are partnering with someone but unmarried, in many cases also ineligible. So that's one reason. There's also some challenges that the sexual minority population may exhibit in building trust with physicians. So even if you have insurance and you are able to go to the doctor, maybe you can't find a doctor that you think that you trust. Okay, and so there's some issues there. In addition, there's been these changes, and I talked about them sort of generally. Certainly the Affordable Care Act, although it didn't have any specific mention of sexual minorities, it had very inclusionary language, and of course the individual mandate that everyone get insurance would have an effect here, even if it wasn't directed at the LGBT population. Probably more important were these two court cases, U.S. v. Windsor and Obergefell versus Hodges. U.S. versus Windsor, which was decided in 2013, summer of 2013, was essentially the repeal of DOMA. And so it said that marriage could not be defined as, at the federal level, marriage was no longer defined as just a man and a woman. This was really important in the context of federal employees at that point started offering benefits to same-sex married people. Okay, so this entire group of individuals became eligible for not only health insurance, but Medicare, Medicaid benefits, some types of retirement, other retirement benefits. It really opened the doors to a lot of financial differences for the married LGBTs. Obergefell versus Hodges was decided 2 years later, and it essentially legalized same-sex marriage in the U.S. Although it wasn't framed in that way, it restricted states' ability to put other types of laws on the books. Okay, so also important, at this point, many employers started offering dependent coverage for same-sex partners. And so there was a lot of changes during this period and how much access to care people had and how much it cost to access that care. So we use the same data to look at access to care, the same 12 groups that we defined before, and we look at 4 different outcomes. First, we look at whether they have health insurance of any type. We ask if they have, we don't ask, the NHIS asks if you have delayed or unmet health care needs due to cost. They also ask if you have delayed care needs due to non-cost reasons. So non-cost reasons are things like you're unable to get an appointment with your doctor, you are unable to get to the doctor's office, you are unable to find a doctor, anything that is restricting your ability to use health care, but that's not because of financial reasons. And of course, some of these are, they're indirectly related to financial reasons also. But they are sort of an interesting adjunct to people not being able to afford. And then there's a question on satisfaction, and it asks whether the people how satisfied they are with care. And so we're looking at people that are less than very satisfied. So anyone who's expresses some dissatisfaction with the care that they received. The base model controls for the same socio-demographic factors. We include a control for survey year because of the changes that are happening during this time. And then the final model controls for employment income and perceived financial strain, with the assumption that the big thing affecting these outcomes is someone's income, right? The NHIS has created, or the NCHS has created imputed income files, so you can actually get point estimates of people's incomes and use them in analyses, which allows us to do this. So the odds of having no health insurance, there's very few differences, either based on race or sexual identity, in the odds of someone having health insurance. We see a little bit of a difference among non-white men who have slightly higher odds of not having insurance. But controlling for these work and income controls reduces almost all of these disparities. And so the upshot of this particular slide is that we find very few disparities very few gaps between straights and the LGBT population in access to care as defined by having health insurance. However, we continue to see some gaps when you're looking at the odds of avoiding care or delaying care. Particularly among women, we see that, say, bisexual women, bisexual white or lesbian white women, almost twice as likely to avoid or delay care based on cost reasons than are straight white men. As you might expect, work and income controls sort of reduce these gaps, although they continue to remain. I don't show a slide for the non-cost reasons, but it looks very similar to this. So individuals although everyone has health insurance, are still not getting care for either financial reasons or some other reason as yet undetermined. Level of satisfaction with care, everyone seems to have the same odds of having lower satisfaction. And once we control for the socioeconomic factors, there are no remaining gaps. And so once people get care, everyone seems to be equally displeased with it. Yeah. This doesn't actually say how many people were displeased, but I think it was fairly high. So summary of these findings, we find no evidence of differences in insurance coverage. This gets an exclamation point because this is something new and sort of surprising. We do see some differences in other aspects of access to care. So the sexual minority population is delaying care for cost reasons, but also non-cost reasons. And this is the thing that we can't answer here, obviously, but sort of makes you theorize about why that might be. Particularly women of color, they have the largest gaps, and in the satisfaction question, the gaps are mostly related to race rather than sexual minority status. So the explanation for these remaining gaps, obviously these patients are not seeking care for some reason. It could be because of lack of discomfort with the providers. So we do not at this point have access to geographic information, but you might theorize that individuals in say Iowa or somewhere where the sexual minority status is not quite as free as the East or West Coast may be less likely to disclose their status and maybe avoid health care for those reasons. All right. So given that we find very few differences in access to care, and that marital status is one of the controls that we use, and given that there were these big changes in the legislation around partnership among gays and lesbians during this time, we took a look at how partnership status affected these same outcomes. Again, we use the same data, although now we add the 2016 data, which had become available. And we define 5 groups by sexual minority status and partnership status. So we have opposite sex married and partnered, same sex married and partnered, and then single LGBs. And single heterosexuals are excluded from this analysis. We ask the same questions about access to care, and we use the same controls, age, sex, race, ethnicity. Obviously sex is now here because it's not otherwise in the groups, and race and ethnicity also not in the other groups any longer. So among these 5 groups, and now we have married opposite sex as the reference category, among these groups, same-sex married people have the same odds of having health insurance as their opposite sex counterparts, but everyone else has slightly higher odds, just barely slightly higher odds, except these opposite sex partnered individuals. So these would be the unmarried partners that have much higher odds of not having health insurance. When we control for our socio-demographics, these are all reduced and become non-statistically significant for the single lesbians and gays and the partnered same-sex, but still remain for the unmarried partners. So, like we saw in the prior study, the differences that we would have expected or we might have expected between the sexual minority population and others are no longer present. Odds of delaying or avoiding care for cost reasons, again, we still see the gaps. So it's sort of a consistent finding that people, if you define access to care as having health insurance, everyone is sort of equal. But if you define access to care as other things, so can you afford the care even though you have a health insurance, we find some differences. And satisfaction, just like we did for the individuals, find that everyone is equally satisfied or dissatisfied with the care that they receive. And so to summarize what we find here, no differences between sexual minorities and heterosexuals and the odds of being insured. Opposite sex partners It's not clear exactly what's going on, why the same-sex partners would be equally likely to be insured as married heterosexuals, but the opposite-sex partners would not, although this is a much larger group. In analyses I don't show, we do show that the reason for the drop, the lessening of this disparity, is because employer-sponsored coverage among the married same-sex couples has increased dramatically. We still see differences or gaps between these groups based on cost reasons. Some ideas. So single LGBs tend to be less wealthy than similar heterosexuals. Of course, we control for income, but single LGBs also have a higher rate of direct purchase of insurance. So they have health insurance, but they're buying it themselves through the marketplace or whatnot. And it's possible that this would reduce their disposable income to a point where they're unable to avoid health insurance or health care. Also, there may be difficulties in finding these LGBT-friendly health providers. And of course, this LGBT group, the residential patterns are distinct. So they live in, the population is overrepresented in the coastal areas and in big cities, and healthcare costs in these places may be higher. So it may be more expensive, and we're seeing that show up in these gaps. So a couple of limitations. Of course, we're using cross-sectional data, so we can't really we don't try to make any causative arguments. And there was this prominent transformation of the healthcare industry during the time. So we try to control for differences by year. And of course, this transformation is what's sort of interesting about the study. But anytime you have these big changes, particularly when they happen in June, it's hard to make a cut on where the change is happening. Although we use 3 waves of a fairly large data set, there's still small samples of some groups. So bisexual non-white men in particular, the sample size is 56 in 3 years of data. And so while we can do the analyses, we get these very wide confidence intervals that are almost not useful. Again, we examine sexual identity rather than sexual behavior because we're looking at the overarching idea here is to look at ways to promote healthy behaviors, and the population that does not identify as gay or lesbian, but exhibits behaviors in that way, may be a different. They may need to be reached in a different way. We'll say that. And of course, we have this restricted definition of gender identity, just male and female, because we're unable to identify transgendered individuals. So where are we going? So it's fairly well established that neighborhoods have an effect on health, which is independent of or interacts with other individual level attributes. And so where you live can affect your health, right? And this may happen directly through, say, environmental reasons. If you live near a factory, maybe your air is polluted. It may happen indirectly through health behavioral factors. So if you live in a suburban area that doesn't have sidewalks, you may be less likely to walk or something of that nature. And so these characteristics of place are affecting outcomes and behaviors. And of course, this has policy implications for health promotion, because some of these disparities that we see may be explained by neighborhood factors. Like I said, sexual minority residential patterns are distinct, and they're different between gay men and lesbians. Gay men cluster in urban areas and within particular neighborhoods within these areas. So Philadelphia, for example, has an overrepresentation of gay men, and the neighborhood, surprisingly, is overrepresented within the city. Lesbians also cluster, but it's not in the larger metropolitan areas, but in smaller and mid-sized cities. And within areas, the lesbian population tends to be more dispersed. So you don't see the clustering in Philadelphia of lesbians that you do of gay men. And of course, no one has any idea where bisexuals live because there's no survey that includes any kind of geographic information on them. I'm going to skip those. So to get this geographic information, we're using restricted use data from the National Center for Health Statistics. The University of Kentucky opened a federal statistical research data center last year, and U of L, University of Louisville, is a member of this consortium. Extremely exciting that we can get access to this data. And what we are going to do is take we need neighborhood identifiers for the data to take variables from the American Community Survey, concatenate them with, or merge them with individual level data, and then include these neighborhood factors in our analyses. And of course, we're looking at a number of things, whether these neighborhood effects moderate, or they may actually increase the differences, the health outcomes that we've seen. They may have effect on health behaviors that affect these health outcomes that we see. And they may affect the influence of other variables. So we may find that education matters a lot, in our analyses, but once we control for place, maybe education is less important. Just an idea. So just to give a shout out to the University of Louisville, given that we hypothesize, or we assume that part of the reason that there are disparities in the actual usage of healthcare services is due to difficulties with finding providers. Many schools have started, I'm just going to use U of L as an example, this LGBT health certificate program. So it's a joint agreement between the medical school and the School of Public Health, and it's basically just a non-academic program that brings in community leaders or academics and sort of teaches people how to be more understanding of these diverse populations. It's free to everyone at U of L, and so many people are taking advantage of it. Many members of the medical community are taking advantage of it. And so the idea, of course, is to make these LGBT-friendly providers sort of more expansive, to get people to be able to use them. Yes, John?
Is there like a certificate or something?
There is a paper certificate, yes.
Is there one like doctors will post on their website or something? So
I have not been in a doctor's office that has it posted yet. But presumably they could do that, yes. So that is all I have. I am happy to answer your questions. I know that was a lot, but I'm happy to answer any questions that you have. Yes.
Yes, this is wonderful. So on the association, I think it's clear cut, but you were surprisingly quiet about the processes driving this. Where, this could be zoning, could be minority sexual orientation driving health, minority sexual orientation, and depending on whether you think sexual identification is stable or very fluid, you would approach that. So I guess I want you to say a little bit more kind of about the next step when you want to go both about kind of what is driving what, but also move away from sexual minority identification being a stable trait to something that possibly responds to a whole bunch of influences. It's less clear what these things mean. So I want to push you kind of on what do you think the next step is that would get beyond these associations?
So what we really need, in my opinion, is more of a longitudinal study that looks at people over time. We can look at sexual identity and see if it's increasing or decreasing based on social acceptance or whatnot, but that doesn't really tell us what is happening for the individual. And so, this is sort of the holy grail of all health research, right? To look at, the longer term and put in all of these changes that are happening. What you describe is obviously the more interesting part of this, but also the more difficult part to come up with answers. I think that we could do more, and I don't intend to, but I think that Ning probably does, on what is the differences between sexual minority status and say race ethnicity. Like what is actually, I show you these gaps, but what is actually happening with these two things? That's it. Yeah. Yes.
So on the marriage, the fact that you found same-sex couples have about the same insurance take up. Could some of that also just be driven by selection in the sense that people were getting married in places, specifically same-sex couples, with the interest of getting insurance? And so if that's the case with this change in federal law, in theory you can look and see if you find an expansion in those couples, or so I guess that's what I'm wondering about that.
Yeah.
It's kind of counterintuitive, but to me it also kind of makes sense if people are purposely deciding to get married because they think this will help them, maybe not in the moment, but at some point soon get insurance.
Right, and I think that certainly happens, and there is certainly some selection into same-sex marriage, particularly in the past, because only in certain places could you actually do it, right? So it's harder to say on that particular aspect, but the fact that the unmarried same-sex partners are also seeing no gap. There's presumably less selection into unmarried status, and so that they're both showing the same thing would suggest that even if this group is moving to this group for whatever reason.
So if they have the change in policy, you should see more people getting married that are same-sex couples to get the insurance. Like that would be a test of that if you had followed.
Unless at the same time that employers are offering unpartnered same-sex benefits, which is happening also during this period. I think the really surprising thing is that the unmarried straights don't see the same benefit, because that's surprising to me. Yeah.
So there's been a lot of research in trying to figure out how to ask these questions, because whether people are willing to answer them one way or the other may be also changing over time. And so you might see just trends happening because people become more comfortable. Now, I think with the ACS, they now ask about same-sex couples, right? There was a lot of research that they were doing. So it may also be that people who live in areas where there are more individuals similar to themselves are more willing to identify. They also may be more liberal in many other ways, like providing benefits. So it would be interesting to see if you can get ACS. They also ask about questions about health insurance. Mm-hmm. So that might give you more leverage and it would have a bigger sample, I think.
So,
just looking at the health insurance coverage per se.
Yeah, the problem with the issue with the ACS data. So the Census Bureau, pardon.
They don't ask about sexual orientation.
Right, exactly. So the Census Bureau, sort of by accident, started collecting data on same-sex couples in 1990 because they had included in their relationship questions unmarried partners, but they didn't. There was no specification of whether it was opposite sex or same sex, and so the 1990 census did that, the 2000 census did that, and the decennial census, and it's carried on to the ACS. The data is kind of a mess because the Census Bureau has done some recoding, and I don't exactly remember which, but in one year they, when they saw that there were people, say 2 men said that they were married, they would change the gender of one of the people, which doesn't make a big deal to the straight population, because this is just one more of a trillion. But for the gay population, this is a big either gain or loss, depending on how you're looking at it. A different year, instead of changing the gender, they changed the marital status to unmarried partner, which seems more legitimate. I don't know any of the background on this. There was probably politics involved. But yes, in terms of looking at partnership and healthcare, access to health insurance, we could use the census.
But I think they also changed the question. There was a lot of research they were doing on how to ask about same-sex couples versus heterosexual couples, and I thought that question was implemented, but maybe not.
Yeah, well, I mean, DOMA was the big problem in how they were going to ask the question. And since it's been, most of the important parts have been repealed, in 2020 they'll ask, you can be any gender and married to any other gender, or unmarried partner. So that won't be as much of a issue going forward, presumably.
I'm curious about the socioeconomic composition of the LGBT population, and and it goes to the question of sorting of, when people answer these questions. There's this image out there that, alternative sexuality is expressed among the more educated, the elites, or something that comes on the, but you mentioned that they tend to be poorer, and so how do they compare to, how homogeneous is also this population? Do you have within that LGBT, do you have the top and the bottom? Or
Yes. So I think that within the sexual minority population, there is more of a larger low-income segment and a larger high-income segment. Okay, so the research on say wages and income has found it's pretty inconsistent, but the general finding is that lesbians earn more than straight women, and that gay men earn less than straight men. All other things equal. This was several years ago. This may have changed. But then you get into partnership, and so if you have two gay men in a couple, then they're going to make more than, say, maybe a married couple, because a man and a woman, the woman may not make as much as, the woman probably does not make as much as the man. So once you add, when you're looking at household income, you have more than this, than just what the individual is earning. So there's this perception of particularly gay male couples having high incomes, and I think they actually have lower incomes, but I think that they have higher disposable incomes because they're less likely to have children. They're also more likely to live in places that actually have higher incomes. So, San Francisco, New York versus Des Moines. I don't know why I'm picking on Iowa, but something like that.
Really quickly related to the Des Moines versus San Francisco, you talk about, it would be very interesting to look at these neighborhood effects, but maybe the bigger difference is not whether you have sidewalks or not, but whether you're in San Francisco or Des Moines. Do you plan on looking at that sort of regional or?
Yeah, so the tract level data that we're going to be using for the neighborhood effects will also have state indicators. Well, not all state indicators. What we really want to know is whether the state is Republican or Democrat, as generally. And
more interested in metro, because big metro areas are blue, even if you're in a red state. You might find a metro state. There are a lot of different ways you can cut it.
Yes, and we presumably could do that. So, have you used the research data centers? I highly recommend it just for the process. It's fascinating how the government works. But you do this proposal, and then if you want to adjust it for anything, then you resubmit it and wait 6 more months, and then they give it back to you. And if you want to change it, then so presumably we will start the research and then do some changes as we find. And these are, of course, good ideas on looking at not just the neighborhoods, but the bigger neighborhoods. Yes.
Yeah, this was very interesting. I have a couple of questions. One of them is that I know you've justified this decision to only look at the identity question, but I'm curious about if you have compared the results if you were using the identity question versus the behavioral one, because that would get us a little sense of what Hans-Peter was kind of getting at the beginning, what is the origin of, are we thinking about these as mostly in terms of discrimination, the result of these gaps, or are they kind of behavioral performative?
Yes.
So, yeah.
So we haven't, and the reason why is because the National Health Interview Survey does not ask about behavior. There's behavioral questions on other surveys. So NHANES is probably the best. You get the best picture of the LGBT population because they ask several questions on orientation, on behavior, on attraction, a whole bunch of different components. So you could do it there, but we have not. But it's certainly certainly there is a selection into this, the propensity to self-identify, absolutely.
And the other question that I had was if you thought about the role of networks. So we know that the LGBT population will cluster in these clusters that you're saying, but that also means that they might have different migration patterns in terms of how much they can rely on kin or parental. I know that there is some research on aging LGBT individuals and how they are much more isolated than straight older people. So I wonder how much of that might also be playing in some of the self-rated health, or sort of the role of networks, friendship versus kin, etc.
Yeah. It's possible to include some of that, probably. I haven't checked, but I think that the NHIS probably has some questions on well, certainly we can identify whether, how many people are in their household, but we may be able to identify other components of that. You know, I'm a geographer at heart, so while like networks that you're describing aren't what I'm necessarily interested in, I'm interested in spatial clustering. So when you have this group that is, say, clustered in the neighborhood, then people may be more free to either go to providers or express their attractions. And so it would be great to be able to control for, you know, who do you live near, say, but that is not, within this data at least, a possibility. Excuse me, I'm not done.
Good job.
Oh God.
I'm sort of going with the identification issue because your bisexual male population is smaller, and even compared to the bisexual women. So I was wondering if that's an identification issue, or if you've seen in other research that is just a smaller population.
It could be an identification issue, but it is in all research, the bisexual male population is smaller than the bisexual female population by a large order. You see the same gap when you look at behavior questions. So women are much more likely to have some sexual experience with other women than men are with other men by a large factor.
I was in Paula England's ASA presidential address too. Totally bad. Yeah. So listen, I'm going to cut you short just a little early because before we give you a round of applause, which we will in just a moment, I'm reminded of something. Next week's session will take place in the new Econ Days. More on that to come. But if you come here, you may sit for a long time before anything in particular.
Why do I have to use the old digs? Doesn't seem fair.
So, so that's it. But Matt, listen, it's really great having you back. This is fascinating stuff. Thanks very much.
Thank you.